on, knowing what the problems are going to be, such as exams in the room, bad lighting, et cetera. And there's some other, solutions that I can mention about how to do that. And then definitely reward, not provide that carrot, but just recognize efforts and recognize when people are going along and doing something different when the change is actually happening. In terms of education, this is kind of a prejudiced way to think about it, but I do believe that some docs just don't listen to information if it's not coming from another doctor. So it's good to build the capacity of a champion or a few within your hospital so that they can then provide the education for their peers. Like I said, walk the talk. You have to model the kind of behavior that you expect, and then spread the news because people do like good PR. The AAP in some ways does embrace the BFHI. They have endorsed officially the 10 steps to successful breastfeeding and the United States Breastfeeding Committee core competencies, all of which are the competencies that would align very nicely with the educational curriculum that you're trying to deliver to fulfill step 2 and to meet those audit tools. Physicians have a role in developing policies at the institution, so it's good to have them on board when it's time to have those conversations around paying for formula or around marketing. Marketing not just in the hospital but in their office practices. It's not going to help if you get rid of all that formula marketing in the hospital and then they go right to the office practices, either prenatal or postpartum, and it's all there instead. And the companies are smart. That's where it's all ending up. So it would be good if the physicians on board said, no, we're not going to take it in our offices either. Understanding the documentation is often one of the challenges, but can actually facilitate decreasing supplementation. So as you're writing supplementation policies, think about how that's all going to be documented. And sometimes just those drop-down menus can actually drive better practice. And then we've mentioned the hypoglycemia and hyperbiliary. Again, understanding all the elements of the code and how that's going to impact. So it seems, pretty simple, straightforward. Get rid of those discharge bags. Show of hands, who's gotten rid of the discharge bags from your hospital? Good work, yay, good job. So that's great. Just as you realize in doing this that you're not going to get the pushback that everybody fears. We actually did this as a study in my hospital. It's a very interesting study that we published, if anybody's interested in reading our saga. But it was very telling. When we did it as part of a study, we wanted to see if it actually made a difference in any breastfeeding or exclusive breastfeeding duration once moms went home. And the research team was wise enough to call moms after they went home to ask those questions. And we asked the question, so did you, and the research assistant had no clue if she was asking a mother that had the original formula company diaper bag or the new bag that had no formula company logos and was from the hospital. They didn't know which bag they got. And they asked the simple question, did you give your baby the formula that was given in the bag? And like 30% of the mothers in the intervention group who weren't supposed to get formula in the bag said yes. And we were like, what? How did that happen? Where were they getting the formula in the bag? And it turns out that when we transitioned to the new non-branded or Cooper-branded diaper bag, our nurses legitimately, we work in Camden, a very poor population. It's hard to get WIC appointments. They were legitimately worried that these babies were either going to starve or the moms were going to give them stuff, like what we've actually shown, such as Coca-Cola or coffee or something other than formula. And so they were stuffing the bags with the 2-ounce Nursats. And in fact, the moms went home, and that was apparently standard of practice in our hospital, was to, just give moms a bunch of, I'm seeing a lot of heads like, yeah, this happens in your place too? here's the rest of the six-pack, just give them the rest of the six-pack. We're not going to use it, and we don't even pay for it. Going home with all these nursettes. And it's interesting because the way this got back to me was halfway through the study, the formula rep screamed at me and said, those nursettes are not for in-home use. They're for hospital use only. Like, she was screaming at me. I was like, what? What are you talking about? What's happening? Like, I had no clue until we got the data back, and it was like, oh, that's what she was talking about. Because apparently it was so obvious that the nurses were stuffing the bags with the 2-ounce nursettes that even the formula reps were aware. But this is before we started paying for a formula, and now we don't have reps on the floor, which is a whole nother issue, in terms of HIPAA violations. So the bottom line is getting rid of the bags is a good thing to do, but really understand the practices and understand the fears of the staff and the other people caring for the babies. And paying for the formula is one strategy. We ultimately decided to incarcerate our formula in the Omnicell. We lock it up. And we lock it up on the bottom shelf purposefully. But really, all kidding aside, this is now our way of being able to track the formula. So we feel much more secure knowing that we track every bit, every ounce of formula that's being used. It's helpful also because we're paying for it. But it also helps eliminate that practice of just stuffing bags or stuffing suitcases with 2-ounce nursettes. We don't even bring in the nursette into rooms anymore. If a baby needs supplements, we just bring in the syringe. Anybody locking up their formula? No, I'm not seeing any hands. So this was, you could use the Pyxis or Omnicell, or you can just use a cabinet and then have a log sheet and actually log the formula that's being used. Step 2, in terms of physicians, this is so bizarre, it's like completely arbitrary. We need 3 hours of education. That doesn't really make sense, given that the staff is getting 20 hours of education, 5 of which is hands-on, because we ultimately have to end up with the same competencies. So, you can get those 3 hours and online and keep track of it, and that's all well and good. Is that going to really change practice? I would beg to question that, because I think that the competencies are from practice, and it would be great, actually, if you could get your physicians involved in interdisciplinary skills fairs. You're at a medical school. I would bet you have a sim lab. We use our sim lab to do every quarter simulated case studies, and we make them interdisciplinary. The nurses are there. The managers are actually there, the lactation consultants, and our faculty and our residents. And we have OB residents and PEDS residents that attend. So interdisciplinary skills fairs work great. And then you really do get the hands-on, and then they really do learn about hand expression. Step 3 for physicians is all about the OB. Rarely do pediatricians see women in the prenatal setting, so it's really important that you have a good relationship with that OB practice. Step 4, you may get a lot of pushback from Step 4 these days because of what's been coming out in the literature, even though there's a great Cochrane review that I've cited here to show all the reasons why skin-to-skin doesn't only help breastfeeding, but is the most stable and safe way to transition a mother and baby after delivery. So that's all well and good. And it can be vaginal or C-section. There are often barriers. We had a funny barrier in our hospital because we didn't have gowns with snaps, so we couldn't put the baby skin to skin without taking off the entire gown. So that was an aha moment. So we went out and got all of our gowns that had snaps so we could unsnap at the shoulders. And it cracks me up because now the whole institution has gowns with snaps. And even in my adolescent clinic, we have the gowns with snaps. And my teenagers can't figure out how to put on these gowns with snaps, which snaps go with which. And I just chuckle because I know why they're there. So you always think about, unintended barriers. One of the things that's really important to know is that skin-to-skin as a procedure doesn't help. That's not the transition we're aiming for. Skin to skin has to be supported and continuous for at least an hour, and this slide just illustrates really nicely that skin to skin less than 60 minutes versus greater than 60 minutes will actually lead to elevated levels of infant salivary cortisol levels. So basically what you can say is if you place that baby skin to skin and you think it's so important that you weigh that baby right now, well, you just need to know that that will increase the baby's stress level. There's evidence that the salivary cortisol will go up. It's not a good thing. Stress is not a good thing for these babies. And so it's important, even if somebody said the baby fed, it's important to maintain skin to skin for at least that full hour. So what's the problem with it? Why might pediatricians be pushing back? Well, just this past summer, Jake Gordon published this article in AP News about these new events. Sudden unexpected perinatal collapse, very scary. We call them sentinel events in hospitals where babies that were otherwise healthy stop breathing, turn blue, may actually require some resuscitation and support. And in this article, he goes on and links it with skin to skin, also with maternal medications that could be problematic, and then goes on and sort of includes issues around bed sharing. So how do we deal with this kind of literature? We invite in Jay and think about the ways to support safe skin-to-skin care without really throwing the baby out with the bathwater, and understanding the conditions that might be linked to increasing levels of sudden unexpected perilocal collapse. This is just the evidence that reports on this situation, but it drives us back to the algorithm step by step. And step by step, these are the things to think about. Delivery of the newborn, drying and stimulating. The baby has to cry first. Open up the lungs, then the cord gets clamped, so not clamping too soon. Giving 1 and 5 minute Apgars while skin to skin on the mom. Continuing to dry, leaving the hands moist for reasons of suckling and rooting. Replacing the wet blankets with pre-warmed dry blankets. Cap or no cap, there's kind of evidence on both sides. And continuously monitoring that dyad. Really not continuously monitoring that dyad throughout that transition, at least throughout that first hour, is hazardous. And I would say, if a sentinel event occurs during that event and nobody's monitoring except for the family, that would be a bad situation. There's also some suggestion, this is actually a list developed by Susan Ludington, of best ways to prevent suffocation or obstruction of the nasal airway, of the nares, which might lead to these SUPC events. So make sure the baby's face can be seen, have that baby in the sniffing position, not too flexed, not too extended. The neck should be straight, not bent. And the shoulders and chest should face mom so that there can be that maximum convection of heat, the baby's temperature remaining stable through convection, and then again covering with those pre-warm blankets and then continuous monitoring. In terms of helping moms to breastfeed, really from a physician standpoint, the one point I would emphasize for physicians is hand expression. Not only if mothers and babies are separated, but as a way to actually begin breastfeeding. This is a great way to show moms she's making something like colostrum and helps the babies to root to the breast. So this is really where we focus. It's great because we can actually point to Jane Morton, who's a pediatrician out in California. She has beautiful teaching videos online, free for use, and the residents use this, our faculty uses this, and we use this for teaching moms how to hand express. And we have some evidence to say, and if mom delivers a preemie and she does nothing but hand express and then begins to pump after 24 hours with hands on pumping, she'll actually make more milk. So it's nice to show that there's some evidence behind hand expression. Not supplementing really is all about not overfeeding. We know that babies that are getting any supplemental feeds are getting more volume than if a baby were exclusively breastfed. In the old days, we would just let them feed ad libitum. We don't do that anymore. We don't give a six-pack of 2-ounce Nursets and let babies go at it, because babies love to suck, and they'll just suck the whole thing down and then start vomiting, and then somebody will say, oh, that baby's allergic to that formula. And babies were not allergic to the formula. They were just overstuffing their very tiny gut. So we did a small study in Boston with Anne to look actually at weight loss as it was stratified by the feeding type. And what we found is that in a baby-friendly hospital, like in Boston, we really didn't have excessive weight loss in those babies. We actually had a mean weight loss of around 6% in the exclusively breastfed babies, but that's probably because their C-section rate's fairly low, fewer interventions, probably less IV fluid. The California studies that were done similarly have shown much more weight loss. The ones that produced those nomograms have more significant weight loss, probably again because of their delivery methods and their C-section rates and how much fluid they get prenatally. What's important to note is that 58 or 59% of the babies reached their nadir by 2 days. That means that a good 40% didn't, and so continued to lose weight even after they left the hospital, driving down that message of how important it is to follow the babies. Pediatricians will push back on jaundice. They think breast milk causes jaundice, and that's not true in the first couple of days. It's just lack of suckling. But we have all kinds of tools from the AAP to help out manage jaundice, and Kinga Sue's published a really nice paper to actually support family-centered phototherapy in the baby with jaundice in the hospital, where moms and babies can be skin to skin. The baby can get phototherapy. Hypoglycemia, this is the policy that should be used. This was developed by the Committee on Fetus and Newborn. These set parameters that should be followed. So 40 is our upper limit, 20 to 40. We refeed only IV glucose for the symptomatic babies or if they're not responsive. So really in the first 4 hours of life, that glucose can go quite low, less than 25. So I don't see 50 anywhere on this. And although I see a lot of 50s and 60s in people's hypoglycemia protocols. Rooming in is all about doing those exams in the rooms, family-centered care. Our pediatricians actually love it now that they've been doing it for a while. They find it more efficient. They actually find that it's very revealing. They actually learn things about the mother-baby diet that they wouldn't have had they examined the babies in the nursery and then examine the moms or talk to the moms about their babies separately. Getting away from these prescriptive times of feedings. This is a pediatrician thing. We like numbers, remember? We like anything that has to do with math and numbers. And so if we're stuck on numbers and we can't just say, let the baby feed ad libitum whenever he wants, like we need a number. If you need a number, get rid of this and get rid of this. But you can say 8 or more in 24. So if you need a number, that's the number to choose. And step 9, in terms of no pacifiers or other nipples, I find the pacifier issue depends on the culture of the physicians in the community, and really separating that message about SIDS prevention, which is not until at least a month of life, versus what's happening in the hospital. And the alternative feeding methods. I find that in hospitals that do a lot of supplementation, they haven't even considered the fact that all that supplementation doesn't have to go in via a bottle. So why no bottles? Well, because we presume that this is a period of sensitive imprinting and that, in fact, getting that pacifier or nipple on a bottle will lead to some element of nipple confusion. So what's the evidence behind that? The notion was first suggested by the WHO that teats might lead to infant suckling confusion. There was a Canadian study that actually looked at healthcare professional opinions. Do you think that giving bottles leads to nipple confusion? And bottle feeding supplements in that community were common, and G-tube feedings were also common in the nursery, and only 15% of the level 2 nurseries agreed that frequent bottle feedings led to nipple confusion, compared to 44% of the postpartum nurses and 56% of the pediatricians. So there was actually more support that you would think that maybe there was this concern about nipple confusion, but still no evidence that it really does. So Cindy Howard did a randomized control trial looking at the effect of cup feeding versus bottle feeding and pacifier use in babies. And really what she found is that it's not so much the cup or the bottle, it's really the supplement by itself. It's really giving that supplement that interferes with prolonged breastfeeding. The best evidence about this whole issue for step 9, nipple confusion, is in the late preterm. And remember, late preterms are part of the BFHI. So in this study, actually, there was evidence that, in fact, cup feedings were better than bottle feedings in breastfeeding late preterm babies. So if you can avoid giving the bottle in these babies, you can help maintain any breastfeeding and exclusive breastfeeding in all cases. So some practical issues she talked about earlier. First of all, people are going to bring in their own pacifiers or bottles. It's actually a nice teaching tool because the nursettes will have 2 ounces, which is not what you want to give the baby anyway. You really want to only give 5, no more than 10 cc's in the whole first, each feed for the whole first day of life. So that's a good teaching tool. So come in with the syringe with small volumes. And then finally, step 10, the pediatricians have a huge role in making sure that families are connected with support groups, but also that they provide that 48-hour follow-up visit to ensure maintenance of exclusive breastfeeding that provides the security when moms are going home. So the BFHI is evidence-based, and physicians are necessary for the implementation. That interdisciplinary care model works best. It's not really us against them. And if we all work together, we can certainly do it. And since I'm from Philadelphia area, I will say, well done is better than well said. And really, you don't have to say anything. If you have all the steps into place, the baby-friendly assessment team won't ask you any questions. They'll just see it. Thank you.
Questions?
Any questions? See, now you know how to go home and engage your physicians.
She did a thorough job then.
Okay, great.
Anne had a comment I know you wanted to make.
No, it's not great.
Yeah.
It's not a comment.
Oh, you're good. Okay, yeah. So no other questions from anybody? Okay. We're going to get all those pediatricians on board, right? Let's see, where's our Chickasaw crew, right?
Taking notes.
Yeah. Okay. All right, Anne?
I just want to say a couple of updates. Thank you, Laurie. So